If you ask anyone what the senses are, they will most certainly mention the five major ones: taste, smell, touch, hearing, and sight. However, these aren't the only senses. Perception is dependent on sensation, but not all sensations are perceived. And so, in this module, we will focus more on receptors, in which they are the structures that detect sensations. We will be discussing 7 different receptors, and these are the taste receptors, olfactory receptors, tactile receptors, periodontal receptors, temperature receptors, muscle joint receptors, and pain receptors. The most obvious exclusion in this list is balance. In terms of physiology, senses can be classified as general or special. A general sense is one that is found throughout the body and has receptor cells in the structure of other organs. This includes mechanoreceptors in the skin, muscles, and blood vessel walls. Environmental stimuli trigger specific receptors or receptor cells in the peripheral nervous system. And so now we go to taste receptors. The sensation we call taste is actually a combination of smell and taste. Flavor is the right term to describe the combined experience of smell and taste while eating and drinking. The term taste should refer to the perceived outcome of stimulating taste receptor cells on the tongue surface. This sense of taste or gustation is similar to the sense of smell, in that stimuli interact chemically with receptors throughout the encoding process. Tasted compounds must dissolve in saliva before interacting with taste receptors. Saliva then holds the dissolved chemicals close to the collections of receptor cells called taste buds. The performance of taste buds deteriorates rapidly in the absence of saliva. The chemical taste receptors are located buried within the bumps, called lingual papillae, that cover the surface of the tongue. In addition to increasing the surface area for taste buds, the papillae create an abrasive surface that helps to hold food within the mouth. In taste buds, taste receptors, it is lemon or goblet-shaped epithelial cells with small pore opening to the mucosal surface. It is about 70 microns in length and 40 microns in diameter. It is approximately 10,000 buds in man. Located on the edges or dorsum of the tongue, epiglottis, soft palate, pharynx, and inside the chinks. The lifespan is 10 to 12 days and are constantly replaced. Composed of 40 to 60 cells of three kinds: taste, receptor, and gustatory cells. Sensory cell or banana shape. Supporting statenticular cell, basal cell. In taste hair, there are slender microvilli extension of the taste cell. In taste pore, narrow opening from where taste hair are projected. In geographic distribution, number 1, wherein the tip of the tongue is sweet, side near the tip is salty, side near the back is sour, and back or rear of the tongue is bitter. In relation to the restorative dentistry, when placing fillings or crowns, pain management ensures that the taste receptors aren't irritated by the materials used. Dentists use local anesthesia to numb the area and minimize any discomfort that could affect taste. In prosthodontics, for dentures and other prosthetics, the focus is on making sure that the prosthetic does not irritate the taste buds. Proper fitting and smooth surfaces help avoid issues that could lead to discomfort or altered taste perception. And in orthodontics, braces and aligners can sometimes cause discomfort. Orthodontists manage this by using techniques and materials that reduce irritation to the tongue and taste buds, helping to keep taste sensation normal while adjusting teeth alignment. In summary, pain management in these areas of dentistry aims to ensure that treatments don't negatively affect taste perception by using techniques and materials designed to minimize irritation.
Olfactory receptors. Olfactory receptors. The olfactory nerves one are special sensory nerves for the sense of smell, and it is also not a single nerve, and olfactory nerve is also the shortest of the 12 cranial nerves. The olfactory fibers cross the skull base through the olfactory foramina of the cribriform plate and enter the olfactory bulb in the olfactory groove. The olfactory bulb proceeds to the olfactory tract, which curses posteriorly at the medial inferior surface of the frontal lobe. So, pain management in olfactory receptors in restorative dentistry. Restorative dentistry deals with dental repairs such as crowns, bridges, and fillings. Dentists use numbing agents and painkillers such as analgesics to ensure you don't feel pain. Even though the olfactory nerves, which aids in smell, it isn't directly involved in the procedure. But this prevents discomfort in your head or nose by calming all the surrounding nerves. In prosthodontics, it deals with making and fitting artificial teeth like dentures or implants. The surrounding nerves are carefully considered when implant placement or prosthetic device adjustments are made. Although there is no direct impact on olfactory nerve, there may be on the trigeminal nerve, which is close to the olfactory pathways. Anesthesia and post-procedure analgesics are useful in reducing pain that may indirectly affect the olfactory nerve surrounding tissue. In orthodontics, it deals with the correction of irregularities of the teeth and jaw, including braces and aligners. Due to pressure on the periodontal ligament and alveolar bone, moving teeth and adjusting orthodontic devices can cause pain or discomfort. Although the olfactory nerve is not directly affected, patient may benefit from indirect pain management by using analgesics or nonsteroidal anti-inflammatory drugs, NSAID, to ensure their comfort.
So now we head on to our next topic, which is the tactile receptors. So this plays a crucial role in our ability to perceive touch and pressure within the oral cavity, which are essential for various activities such as chewing, swallowing, and of course speech. These receptors help in detecting mechanical stimuli such as pressure, vibration, and touch. So let me discuss the key aspects of tactile receptors in oral physiology. We have two types of tactile receptors. The first one is mechanoreceptors. These are sensory receptors that respond to mechanical pressure or distortion. In the oral cavity, they are primarily low threshold mechanoreceptors, meaning they respond to very light touch. Mechanoreceptors are crucial for detecting various physical properties within the oral cavity, including the texture of food, the force applied during chewing, and the position of the tongue and teeth. These receptors are essential for the proper functioning of the oral system, contributing to activities like mastication, speech, and, of course, sensory perception. Second one is the cutaneous mechanoreceptors. These are a subset of mechanoreceptors specifically located in the skin, while mechanoreceptors in oral physiology focus on the structures within the oral cavity. These are primarily concerned with the skin's response to external stimuli. However, in the context of oral physiology, cutaneous and mechanoreceptors refers to those located in the skin of the lips and face, which are still relevant to oral functions. So, under the cutaneous mechanoreceptors, there is first we have Pacinian corpuscles. These detect deep pressure and vibration. They are located deep within the dermis and subcutaneous tissue, and their rapid adaptation allows them to respond quickly to changes in pressure. These receptors are crucial for perceiving vibrations through objects, such as detecting the texture of the food during chewing. The next one is Meissner corpuscles, sensitive to light touch and changes in texture. These are highly sensitive mechanoreceptors found in the dermal papillae, particularly in areas like fingertips, lips, and your tongue. They are responsible for detecting light touch and changes in texture, making them essential for tasks requiring fine tactile discrimination. Their rapid adaptation enables them to quickly respond to subtle vibrations in surface textures. Lastly, we have Ruffini endings, skin stretch, and sustained pressure. Ruffini endings are slowly adapting mechanoreceptors found in the deep dermis and connective tissues like the periodontal ligament. They sense skin stretch and sustained pressure, playing a key role in the proprioception and the perception of object manipulation. These receptors help in detecting the direction of stretch, which is important for maintaining grip and posture. So, the location and its function for the oral tissues, tactile receptors are found in various oral tissues, including the epithelium of the lips, cheeks, and tongue, of course, as well as the palate. The periodontal ligaments, which attach the roots of the teeth to the surrounding alveolar bone, also contain mechanoreceptors. Then, the sensory innervation, the tactile sensory innervation of the teeth, is located in the periodontal ligaments. These receptors help in detecting the force and the pressure applied during the activities like chewing and speaking. Importance: chewing and speaking. Tactile receptors help in the precise control of movements during chewing and speaking by providing feedback on the position and pressure of the tongue and other oral structures. In protective reflexes, these receptors also play a role in protective reflexes such as preventing damage to the teeth and oral tissues by detecting excessive pressure. Tactile receptors in oral physiology are crucial for detecting and processing sensory information related to touch, pressure, and texture within the oral cavity. Again, they play a vital role in mastication by providing feedback on the size, consistency, and texture of food, ensuring efficient chewing and safe swallowing. These receptors also contribute to the speech articulation by enabling precise movements of the tongue, lips, and jaw. Additionally, tactile receptors aid in proprioception, allowing the brain to monitor the position and movement of the teeth and oral structures, which is essential for maintaining proper occlusion and preventing injury. They enhance the overall sensory experience of eating by integrating texture and temperature sensations with taste, influencing flavor perception. In clinical settings, understanding the functions of these receptors is important for designing effective dental prostheses and managing sensory impairments.
Types of preceptors present in PDL. Nociceptors for pain, which perceive painful stimuli which result in both pain perception and reflex responses by rapidly opening of the mouth. Next, mechanoreceptors, which respond to physical deformation of the plasma membrane caused by touch and pressure. Next is the mechanoreceptors for detecting tooth contact during the function and reflex control the mandibular movement and play an important role in the control of the masticatory cycle. Types and distribution of neural termination in PDL. Free endings have a tree-like configuration which include nociceptors or pain receptors that carry pain sensation through a small diameter nerve fibers. Next is the Ruffini-like mechanoreceptors, or flatted, elongated capsules containing a few nerve fibers. They respond tonically to heavy, continuous touch or pressure located primarily in the apical area. Next is the tactile Meissner's corpuscles. Also, mechanoreceptors are tall, ovoid to pear-shaped, consist of 2 or 3 nerve fibers, and are phasic receptors for light touch, texture, and low-frequency vibration are found mainly in the midroot area. The periodontal ligament is richly innervated by mechanoreceptors whose cell bodies are located either in trigeminal ganglion or mesencephalic trigeminal nucleus. Both are sensitive to stretch of ligament induced by tooth movement, but they are different in central connections, and functional significance. There are 2 types of adaptation of the mechanoreceptors. First is the rapidly adapting receptors, are loosely attached to the surrounding tissue, and slippage occurs during the sustained displacement of the tissue. They could function to signal initial contact with food or opposing teeth. Next is the slowly adapting receptors, are those which are more firmly attached to the surrounding tissue. They are useful for discriminating tooth-stimulated the stimulus direction intensity and change of pressure applied to the tooth.
Temperature receptors or thermoreceptors are specialized nerve ending in the skin that enables to detect temperature changes. These receptors plays an important part in how we detect and respond to our surroundings, allowing us to keep a normal body temperature and avoid potential injury. There are 2 types of thermoreceptors. Each is responsible for different thermal sensation. Cold receptor are small sensor found in our skin outer layer known as stratum basilae. These sensors are attached to neurons that are covered in a protective layer, allowing them to relay messages quickly. These cold sensors become active when our skin temperatures drop between 10 Celsius to 40 Celsius. When they sense this range of cold, they send signals to our brain indicating that our skin is feeling cold. These allow you to know when you are in a cooler environment. Warm receptors are specific sensors found deeper in the skin, in a layer known as dermis. They are attached to a thinner nerves that lack a protective layer, which signals are sent more slowly. When our skin temperature ranges from 32 Celsius to 48 Celsius, these warm receptors activate. When they detect warmth in this range, they send signals to our brain indicating that your skin is warm. These allow you to recognize when you're in a warmer area. Both type of temperature sensor in the skin, cold and warm, react when the temperature changes. At first, they provide strong stimuli to the brain, but if the temperature remains constant, they slow down and send less signal. However, when the skin becomes too cold below 10 Celsius or too hot over 48 Celsius, the sensation changes from cold or warm to discomfort. This occurs when pain senses take over, indicating that the temperature is unsafe. Thermoreceptors are known as functional receptors because they transform temperature changes into electrical signals that the nervous system can process. These signals let the body to behave appropriately, such as feeling chilly or warm or recognizing when something is hazardous. Tooth sensitivity after dental work. When you get a filling or a crown, your teeth might become more sensitive to hot or cold things. This happens because the temperature sensor inside our teeth, located into the dental pulp and tissue around it, react to the changes caused by the dental procedure. This sensor can become more alert, making you feel sensitive that you didn't notice before. Anesthesia. During dental procedure, local anesthesia is used to numb the area, which block pain signals, including those from temperature sensor, so you don't feel discomfort. However, once the anesthesia wears off, this temperature sensor may become more sensitive, causing you to feel the heightened reaction to hot or cold. This is why some people experience increased temperature sensitivity after the numbness goes away. Prosthetic sensitivity. When you receive new denture, crown, or bridges, they can affect how you sense the temperature in your mouth, particularly when it comes to hot or cold foods and drink. Natural teeth have an outer layer of enamel that acts as sort of insulation, helping to moderate the sensation of heat or cold before it reaches the inner part of the tooth, where the nerves are located. This insulation provides a buffer so the temperature changes are not as immediately noticeable. However, dental prosthetics like metal crowns or bridges don't offer the same protection. Metal, in particular, are very good conductor of heat, meaning they quickly transfer temperature changes to an underlying tooth or surrounding tissue. This can make you more sensitive to hot or cold sensation, especially if the tooth underneath is still alive and has nerve tissue that can react to those changes. Temperature discomfort. When you first get a new dental prosthetic like dentures, crown, or bridges, your mouth might feel a bit different. After the prosthetic is adjusted, it takes time for your mouth to get used to it. You might notice that your teeth or gums are more sensitive to hot or cold temperature. This is because the new prosthetic can change how temperature is felt in your mouth. For example, metal crowns can make your teeth feel hot or cold more quickly. This extra sensitivity is usually temporary. Over time, your mouth will adjust to the new prosthetic as your mouth adapts. The discomfort will likely decrease, but if the sensitivity persists or causes problem, it is a good idea to talk to your dentist. Adjustments. When you get your braces adjusted, you might feel some temporary discomfort and increased sensitivity to hot or cold temperature. This happens because your teeth and gums are adjusting to the new pressure and can change caused by the braces. Your mouth needs a little time to get used to this adjustment. Aligners. Clear aligners gradually shift your teeth into place. This process can also lead to temporary discomfort and more sensitivity to temperature. This pressure from the aligners can make your teeth more responsive to hot or cold, and you might notice this change as your teeth adjust to the aligner. Muscle and joint receptor are key components of your body's sensory system, supplying vital information on the position and movement of our limbs, as well as the force acting on your muscles and joint. They aid your body's senses of direction or sensation of location and movement. These receptors constantly communicate with your brain about the strain, tension, and pressure in your muscles and joints.
Muscle joint receptors. In the field of dentistry, muscle joint receptors are important, especially when it comes to occlusion, disorders of temporomandibular joint, also known as the TMJ, and the general oral function. So, muscle joint receptors is connected to the pain management in the field of dentistry. So, pain detection. Pain in the jaw, particularly in the temporomandibular joint or the TMJ, and the chewing muscles, can be detected by the muscle joint receptors. These receptors transmit pain signal to the brain when there is an issue, such as teeth grinding or misalignment of the jaw, which can cause headaches or jaw pain. Next is the TMJ conditions. These receptors may become overly sensitive in TMJ disorders, which cause the jaw joint to become stressed or misaligned and result in persistent pain. So, in order to alleviate this pain, the dentist realign the jaw or apply mouth guards to lessen the joint stress. Bite and alignment. These receptors aids in the communication between your jaw muscles and your teeth's proper mastication. So, an incorrect bite can put excessive stress on the muscles and to your TMJ, which can be very painful. So, the dentist can release this pressure by adjusting your bite. Last is the anesthesia. So, in order to effectively block pain, dentists that administer shots to numb an area prior to a procedure do so by targeting the nerves that are connected to these receptors. So, muscle joint receptors are essential to dental care because they play a major role in the detection and treatment of pain in the jaw and face.
In pain receptors, pain is a discomfort caused by tissue injury or nauseous stimulation, mediated by specialized free nerve endings, called nociceptors. Nociceptors are sensory neurons that respond to potentially damaging stimuli by sending signals to the spinal cord and brain. They are found in various tissues including the oral cavity. Myelinated axon is fast pain and prickling pain. Unmyelinated axon is low pain or burning and aching. In somatic pain, pain on the skin, muscles, and joints. It is superficial skin and deep muscles, joints, and tendon. In visceral pain, stimulation of receptors in internal organ, abdomen, and skeleton. Poorly localized and fewer receptors. It can be referred. And lastly, referred pain. Pain experience is distant to its point of origin. Area of referred pain is supplied by same spinal segments as actual site of pain. Brain misinterprets signals as coming from somatic regions.
Let's head on to the classification of pain receptors. Pain receptors or nociceptors can be classified based on the origin of the stimulus that they detect, such as external exteroceptors, internal interoceptors, and proprioceptor sources. Now let's further discuss those sources. Let us begin with exteroceptors. Exteroceptors, an immediate external environment impulses being sensed at conscious levels. Exteroceptors are sensory receptors that detect stimuli from the external environment such as touch, temperature, and pain. They are located in areas like the skin, oral mucosa, and other surface exposed to the external environment, enabling the perception of sensory information at a conscious level. These receptors are essential for interacting with and responding to immediate surroundings. Under exteroceptors, we have free nerve endings. These are tactile and superficial pain. Free nerve endings are simple nerve receptors located in the skin and mucous membranes responsible for detecting tactile sensations and superficial pain. They respond to a variety of stimuli, including temperature changes and harmful mechanical forces, playing a critical role in the body's protective responses. These receptors are important for sensing sharp prickling pain and involved in the initial perception of injury. Next is Krauss corpuscles. These are cold receptors. Krauss corpuscles are specialized sensory receptors found in the skin and mucous membranes that primarily detect cold temperature. They are encapsulated nerve endings that respond to a decrease in temperature, contributing to the sense of cold. These receptors help maintain body temperature by triggering responses to cold environments such as shivering. Next is the Meissner corpuscles, known as tactile skin receptors. These are rapidly adapting mechanoreceptors located in the dermal papillae of the skin, particularly in areas like the fingertips, palms, and soles. They are responsible for detecting light touch and changes in texture, making them essential for tasks that require fine tactile discrimination. These receptors allow for the detection of slight movements and textures on the skin surface. Merkel's corpuscles. This is tactile sensation on the oral mucosa and the submucosa of the tongue. Merkel's corpuscles, also known as Merkel cells, are mechanoreceptors found in the basal layer of the oral mucosa and submucosa of the tongue. They detect sustained pressure and texture, contributing to the fine tactile sensation needed for tasks like speaking and manipulating food in the mouth. These receptors are important for detailed tactile perception and play a role in oral sensory experiences. Next is the Ruffini's corpuscles, known as the pressure and warmth receptors. Ruffini corpuscles are slowly adapting mechanoreceptors located in the deeper layers of the skin and connective tissues, including the oral cavity. They respond to sustained pressure and warmth, playing a key role in sensing skin stretch and temperature changes. These receptors contribute to the perception of steady pressure and thermal sensations, aiding in proprioception and thermal regulation. Now we head on to the interoceptors. Interoceptors are sensory receptors located within the body cavities responsible for detecting internal stimuli such as blood pressure, stretch, and visceral pain. They serve involuntarily bodily functions below conscious levels, regulating processes like digestion, respiration, and cardiovascular function. These receptors are crucial for maintaining internal homeostasis and triggering reflexive responses for internal changes. Under that, we have the free nerve endings, perception of visceral pain within the organs. Free nerve endings within internal organs are responsible for detecting visceral pain, which is often diffuse and difficult to localize. These receptors respond to harmful stimuli such as tissue damage, inflammation, and stretching within the organs, alerting the body to potential internal issues. Visceral pain is often experienced as deep aching discomfort and is crucial for identifying the internal health problems. Lastly is the Pacinian corpuscles. These are perception of pressure inside the body. Pacinian corpuscles located within the body cavities detect deep pressure and vibrations inside the body, such as these occurring in the blood vessels and internal organs. These rapid adapting mechanoreceptors provide sensory feedback on changes in the internal pressure, contributing to the regulation of functions like circulation and organ movement. They play a key role in the body's ability to sense and respond to internal mechanical forces. And lastly, we have proprioceptors. It is an automatic functioning and perceived movement, pressure, and position. Under that, we have the free nerve endings. These proprioceptors are responsible for detecting deep somatic pain and various other sensations, providing critical feedback about potential damage or discomfort in tissues. In oral physiology, they help in sensing pain and other distress signals from the oral cavity. Next is the Golgi tendon organs. It is positioned between muscle tendons. These mechanoreceptors monitor muscle tension and length, sending information to the brain to regulate muscle force and prevent injury. They help in adjusting muscle activity during oral movements like chewing. Next, muscle spindles. It is located within the muscle fibers. Muscle spindles detect changes in muscle stretch and length, aiding the precise control of muscle movements in the oral system. They contribute to the coordination of muscle activity for functions like speaking and chewing. Pacinian corpuscles. These receptors sense rapid pressure changes and vibrations, allowing for the detection of pressure variations in oral tissues. They are crucial for perceiving and responding to dynamic changes in pressure during oral functions. Lastly, periodontal receptors. It is found in the periodontal ligament surrounding teeth. These proprioceptors detect tooth movements and the forces applied to teeth. They provide feedback necessary to the regulations of biting and chewing forces, ensuring proper dental function.